Hello everyone, welcome to my YouTube channel. Now we will talk about fever of unknown origin. We will study it from the chapter number 20 of Harrison's textbook. Now pyrexia of unknown origin or fever of unknown origin. We should know the definition of PUO. It is defined as fever more than 38.3 degrees Celsius or more than 101 degree Fahrenheit on at least 2 occasions. Illness duration should be of more than equal to 3 weeks. There should be no known immunocompromised state. And there are some obligatory investigation which should have been done in the case of pyrexia of unknown origin, and they all should be normal. First of all, history taken and physical examination, both of them should be normal. And obligatory investigation. Obligatory investigation include ESR, CRP, both should be normal. Then platelet count, TLC, DLC, HB, serum electrolyte, serum creatinine, total protein. Then liver function 10, alkaline phosphatase, alanine aminotransferase, that is AST and ALT, and aspartate aminotransferase, AST, ALT, and ALP, lactate dehydrogenase, creatine kinase, serum ferritin, which is a marker of inflammation, then ANA, RA factor, they should be negative. Protein electrophoresis should be normal. Urine analysis. According to the definition, urine culture, a single urine culture is enough, should be negative. Blood culture, 3 blood culture are negative. Okay, urine culture, blood culture. Then chest x-ray should be normal. Ultrasound abdomen. This is very important. CT is not included in the obligatory investigation. Ultrasound abdomen is included in obligatory investigation. Then TST or IGRA, any of the two. Tuberculin skin test or IGRA, any of the two can be used in obligatory investigation. Now, one more term we should learn about is IUO. IUO is inflammation of unknown origin. The definition is exactly similar to PUO, except in case of PUO, first criteria is fever. In case of IUO, first criteria is increase in ESR or CRP or both. Here there is no increase in inflammatory marker. Here there is no fever. This is the difference between IUO and PUO. But the workup for IUO and PUO is same. Now the causes of pyrexia of unknown origin. Most common cause is infection, and in infection most common cause is TB. Then second most common cause is neoplasia. Inflammation more than neoplasia. Now we should learn about the protocol in case of pyrexia of unknown origin or inflammation of unknown origin. First of all, the diagnostic criteria should be fulfilled, that is fever more than equal to 38.3 degrees Celsius or more than 101 degree Fahrenheit, more than equal to 3 weeks, and there is no immunocompromised state. Once this is fulfilled, then we should undergo history and physical examination of the patient. What should we ask in the history? History should include the fever pattern, the drug history, recent travel history, sexual history, environmental exposure, previous medical history. These are important history. Then in physical examination of lymph node, spleen, respiratory system examination, liver, CNS system examination, and CV system examination is must. The next step is to stop the antibiotic treatment and glucocorticoid. Since blood and other culture are not reliable if patient is on antibiotic treatment. And in case of glucocorticoid therapy, if patient is having lymphadenopathy, then glucocorticoid can decrease the size of the lymph node. Then we should perform the obligatory investigations. Obligatory investigation, we have already discussed all of them, that is ESR CRP, HB platelet count, TLC and DLC, liver marker, that is AST, ALT and alkaline phosphatase, LDH, serum creatinine, total protein electrophoresis, creatinine kinase, ANA, RA factor, blood culture, that is equal to 3, that is very important, and urine culture is 1, and chest x-ray, abdominal ultrasound, and tuberculin skin test or IGRA. Performing more than 3 blood culture or more than 1 urine culture is useless in patient of pyrexia of malnutrition. Repeating blood culture and urine culture is useful only if the patient was on antibiotic and now he has stopped the antibiotic. After 1 week of its discontinuation, if we are doing blood culture again, then it is useful. Then most important thing is to exclude the manipulation with thermometer that we have discussed in the previous video, that is fraudulent fever and factitious fever has to be ruled out. What is fraudulent fever and what is factitious fever we have already discussed in previous video. Okay, so we have done till now history, physical examination. We have stopped antibiotic and glucocorticoid. Then we have done with obligatory investigation, which all have become normal. And then we have ruled out fraudulent and factitious fever. Then we have ruled out drug fever. Drug fever, if we have stopped the drug for more than equal to 72 hours, then cause of fever cannot be the drug. Then we have most important thing in pyrexia of unknown origin. Most important step is this: potentially diagnostic clue is present or not. If there is potentially diagnostic clue, then such as in ultrasound we find the liver abscess. If potentially diagnostic clue is present, then diagnostic test we will do. If diagnosis is made, then it is okay. If potentially diagnostic clues are absent, then we will go for cryoglobulin and fundoscopy to rule out any vasculitis, fundoscopy to rule out retinal vasculitis, cryoglobulin to rule out cryoglobulinemia and vasculitis associated with it. If these all are negative, then we have to go with FDG PET CT scan. This FDG is fluorodeoxyglucose PET, positron emission tomography. FDG PET FDG accumulate in tissues which have high rate of glycolysis. So in case of inflammation or infection, there will be high glycolysis because there is increased metabolic rate. Okay, so this occur in malignant cell. Increased glycolysis occur in malignant cell and in chronic inflammatory processes, acute or chronic inflammation. So there will be increased uptake and we can find the location of the disease. Okay, from that location, from where the scintigraphy is abnormal, we can do the diagnostic testing. But Physiological uptake of FDG may obscure pathological foci in this tissue, like brain. Brain itself has a very high metabolic rate, that is FDC. FDC is normally increased, uptake is normally increased in the brain tissue. Okay, so we cannot rule out any disease related to brain, heart. Infective endocarditis is difficult to rule out with the help of PET CT. And second is pathological FDG PET, like in vasculitis. It should be positive, or in lymphoma, it should be positive. But think we have given patient glucocorticoid. Glucocorticoid will decrease the inflammation, decrease the vasculitis, decrease the lymphoma. So FDG PET will be falsely negative in these conditions. And then is temporal arteritis. In case of temporal arteritis, vessel is so small, so FDG PET uptake cannot be seen. So if there is no diagnosis with the help of FDG PET, we have to perform temporal artery biopsy if patient is more than 55 years. CT chest and CT abdomen. With this, if there is diagnosis, if there is no diagnosis, then what we have to do? If we reach to diagnosis, if no diagnostic clue is there, now what is the step? If there is no diagnostic clue, if we reach to the diagnosis, then treat the diagnosis. If there is no diagnostic clue, then if patient is stable, we have to consider NSAIDs. If patient is deteriorating, we have to give the therapeutic trial of ATT. But if there is no response after 6 weeks of ATT, then probably there is no TB. One most important thing in this is investigation for pyrexia of unknown origin should not be done. Which investigation should not be done blindly? 2D echo. Unless there is potentially diagnostic clue, 2D echo should not be done. Liver biopsy, bone marrow biopsy, or any invasive procedure like spleen biopsy should not be done. Now, one more therapy related to pyrexia of unknown origin is interleukin 1 receptor modulators. Interleukin 1 is key cytokine in systemic inflammation, and it is main cytokine we have studied for febrile response. So we can use interleukin 1 blocker, interleukin 1 receptor antagonist, like anakinra, mainly used for autoinflammatory diseases, because main role of interleukin is there, like familiar Mediterranean fever. Okay, autoinflammatory disorder, that is inflammation of unknown origin. So that is all about pyrexia of unknown origin. Thank you so much.